Hello, my name is Megan Moore. I will be teaching you guys about irritable bowel syndrome. Okay, so the pathophysiology of IBS. So a couple different things. I just want to go over the normal function first, just as a quick reminder, just so we know what we're starting with as a baseline. So the normal function of IBS is that peristalsis movement through the small and large intestine, which helps the stool travel so we can have bowel movement. So that normal bowel movement can be anywhere from 3 times a day to 3 times a week. It's very different for everybody. It's very individualized. So anything more than 3 times a day is considered diarrhea. Anything less than 3 times a week is considered constipation. So in our patients, we're going to see a large variety of what their normal is, but it is very important to ask those questions on what is their normal to start with your baseline. So the National Cancer Institute defines IBS as a disorder of the intestines commonly marked by abdominal pain, bloating, and changes in a person's bowel habits. So it's that change in the bowel habits that we really want to concentrate on. So the patho. So it's really unknown exactly what causes IBS or really what's happening, but there are a lot of theories on what it could be. So 3 different things are the major causes. So it can either be psychosocial or psychological. It could be due to like a post-infection, so a gastroenteritis, or it can be due to gastric motility. So psychosocial, there is about 50% of people that are diagnosed with IBS has an underlying psychological cause. So that could be either anxiety or depression or like high amounts of stress. It's that connection between the brain and the gut that is disconnected. So that can be part of it. Then the post-gastroenteritis, that's the bacterial infection in the digestive tract, especially in the colon, and it's seen post-infection. So anywhere from a month to 6 months out, it's fairly common to develop IBS because of that. Again, not exactly sure why, but it is just seen in patients and it's been highly researched. Then with gastric motility, we have 3 kinds. So we have IBS-C, IBS-D, and IBS-M. Each classification of IBS is due to the symptom with it. So IBS-D is due to diarrhea, IBS-C is due to constipation, and IBS-M is a mixture of both diarrhea and constipation. So with that said, we will go on to exactly what's going on. Okay, so which patients are we going to see this in? So we're going to see this in women about twice as much as we are in men, and it's going to be under 50 years old. A lot of times we'll see patients in their 20s, sometimes their teens, up until 50. If it's starting to get closer to 50 or they're over 50 and older, then that's probably going to be something a little bit different. So that's an important factor. Also, family history. So especially direct related. So mom, dad, siblings. That's going to be something that puts you at higher risk for developing IBS. Lifestyle, so people that smoke and drink, as per a lot of other diseases, that's going to put you at higher risk, plus taking certain medications like antibiotics or high doses of antidepressants, or if you eat a lot of food that could trigger your IBS, and we'll get into that too. Recent infection, like I said before, that bacterial gastroenteritis can also be an effect on developing IBS. Another thing that also puts you at risk is having food sensitivities. So gluten, lactose, wheat, stuff like that, that you are sensitive to can put you at higher risk for developing IBS in the future. Okay, so what are our patients going to look like? So the patients that we're going to see in the office are going to be highly individualized. It's different for everybody, but the most common symptoms are the ones listed here. So patients are going to come with abdominal pain. So that lower abdominal crampy pain. And the biggest thing to note is that it's going to get better with defecation. That's that light bulb in your head that's going to go off. Is if it gets better with defecation, it is most likely IBS. Other symptoms that they can have is diarrhea or constipation, like we talked about, depending on what classification of IBS they have. Flatulence, bloating, nausea. They can also get a headache or a backache. It's a little less common, but it can happen. And then loss of appetite, just because you know what's going to happen if you eat, and that can be a little bit more cautious with eating. Those red flag symptoms, though, that we want to look out for, that really round, distended abdomen, nocturnal diarrhea, incontinence, loss of that ability to hold it, severe uncontrolled pain, unexpected weight loss, trouble urination, any of those crazy symptoms. IBS is mostly, like we talked about before, any of those red flag symptoms are something that may be a little bit more serious or emergent. So those are those symptoms that won't necessarily mean it's IBS, but is just definitely something to differentiate between an emergent versus non-emergent IBS bout. So these patients that are coming in are going to be telling us a lot of subjective information. So like I said before, it's really important to get that history and physical super detailed, and just making sure that we get all of the information that they can tell us, because their physical exam is going to probably be pretty unremarkable. If anything, it's going to be those secondary symptoms. So abdominal pain, it may be tender upon palpation, or if they have like dehydration due to a lot of diarrhea, then we're going to see a pale, fatigued patient, maybe with some dry mucous membranes. So nothing that's going to scream at us at the physical exam, but like I said, we want to be really detailed with that subjective information, and try to get all the information that we can from the patient on the interview part. So my differential diagnoses, so a lot of GI diagnoses kind of share the same symptoms, so it can be hard to differentiate between certain diagnoses. So my different ones are inflammatory bowel disease. It does have a lot of the same symptoms: diarrhea, that abdominal pain, ulcerative colitis, diverticulitis. Those also have diarrhea and abdominal pain with it. The gastroenteritis, the viral or bacterial, so that can put them at high risk for IBS. So we want to make sure that they're not actually active infected, but that would come with a fever and more severe abdominal pain. The food intolerance or allergy may be hard to differentiate with the IBS at first, but that is also part of our differential diagnoses. And then, of course, the thyroid disorders, hyper or hypothyroid, can affect your bowels as well. So diagnostic. So how are we going to figure out that this is IBS? So this slide here, I just wanted to include is a great flow sheet. I'm a very visual person, so something that lets me read through my options and kind of help me make that decision is always really helpful to me. So this goes through diagnostics and testing and things to watch out for and everything. So just a good tool. We'll see this again in a little bit. So our diagnostics. So the gold standard for diagnosis is the Rome 3 criteria. So as you can see in the table, the Rome 3 criteria is the abdominal pain or discomfort for equal to or greater than 3 days per month, and then it has to last at least 3 months. A lot of gastroenterologists will say 6. And then associated with 2 or more of the following. So that's the pain or discomfort improved with defecation, like we had talked about, that light bulb of a symptom, and then the onset associated with the change in frequency and or appearance of the stool. So that's either alternating between the diarrhea and constipation, or the frequency less or more. And like the biggest thing is that these patients should not show any type of evidence of the inflammatory, anatomical, metabolic, or neoplastic process that could cause these symptoms. So something like that is going to put us in a different direction and is going to make us think of something a little bit more serious with our diagnosis versus IBS. So this is a great table and the criteria that we would use to diagnose these patients. So to diagnose, like I said, we're going to use the Rome 3 criteria. It's basically ruling out any other symptoms. So just making sure that they don't have any type of other symptoms that would pull us in a different direction. We're not going to do really any diagnostics. Laboratory work and scans just really aren't necessary. They can be expensive and invasive, and these patients, you just don't need them for unless they're having pretty severe symptoms. Some gastroenterologists will recommend a blood test to rule out celiac disease because it can mimic IBS. But usually with lifestyle changes, you can avoid the poke. So how are we going to treat these patients? So once they're diagnosed, we want to come up with a plan. So our plan of care is going to be highly based on non-pharmacological interventions. So mostly it's going to be lifestyle changes and avoiding any trigger foods. So if they are not sure what would cause their IBS, then a food diary will be a great way for them to start realizing what is going on and how they can avoid food. So if they're consistently getting diarrhea after eating bread or wheat or something like that, then we can see in their diary that that's what's going on. So we're going to tell them to avoid any gas-producing foods. So the fructose, lactose, beans, lentils, stuff like that. Veggies like cabbage or broccoli. We want them to stay away from that because that could trigger it or make their bloating worse. Avoiding gluten can always help. And then we're going to instruct them to follow the FODMAP, the FODMAP. That is a new diet that gastroenterologists are recommending. They're seeing an 86% success in IV patients. So IBS, patients. So this diet is basically avoiding dairy, beans, lentils, those fruits and veggies that are gas producing. And they're basing it around these eggs, meats, almond milk, grains, veggies like tomatoes, cucumbers, zucchini, and fruits that are good like grapes, oranges, strawberries, blueberries, stuff like that. So it's a diet that they would use. There's a bunch of apps for it, but they're seeing a large good rate with it. So we want to make sure that they want patients with IBS to follow. And then once they follow it, they can start adding some things back. And then if they added something that's a trigger, then that will help them differentiate their triggers as well. So patients with constipation, we want to have them drink lots and lots of water. We want them to increase their fiber. And like I said, just really make sure they're staying hydrated. referrals might need to be made to like a dietitian or a gastroenterologist to help them find their triggers if the diet is not working. But usually with the diet and lifestyle modifications, that we can get it under control pretty well. If it's more of a psychosocial or psychological trigger, then we can give them ways for stress reduction. So yoga, meditation, exercise, finding a hobby that can be relaxing to them, regular exercise that will release those endorphins, anything that will help take that psychological aspect out, or at least reduce it. We can always encourage talk therapy or counseling to really help with the getting through any type of depression or anxiety or anything along those lines. So that's the non-pharmacological. Now we'll go on to the pharmacological. Okay, so our pharmacological interventions are going to be secondary to our non-pharmacological. It is preferred that you do non-pharmacological first, just because they're usually more effective and cost-effective. But our pharmacological interventions are going to be just supportive of whatever symptoms they're having. There's no cure for IBS, so we're just going to hopefully treat the symptoms and hopefully make them a little bit more comfortable. It's those lifestyle modifications that are going to help avoid any triggers or any flare-ups of IBS. So medication-wise, we can treat several of the symptoms that come with IBS. So we can do peppermint oil or dicyclomine for the abdominal pain and cramping. We can do antidiarrheals for the IBS-D, which could be over-the-counter or prescription, depending on how severe their symptoms are. We can do laxatives, so milk of mag or Miralax, or stool softeners like Duclax, depending on what the patient's preference is to treat the IBS-C, so the constipation. For bloating or gas, we can do simethicone or probiotics. The probiotics have been highly effective in IBS, especially for the IBS-M. We can do the rifaximin. So rifaximin is an antibiotic that just got recently FDA approved to help the treatment of IBS. So that is an option for the diarrheal patients. Our last ditch effort for our diarrheal patients is allosterone. It is a peristalsis medication that slows peristalsis and helps reduce the pain that comes with that. So it's our last ditch effort because it has some pretty severe side effects. It can cause pretty severe constipation, which can lead to bowel obstructions and severe pain and such. So that's our very, very last ditch, severely sick patients that nothing else has worked. There's also been a lot of research on low dose SSRIs. So as we know, SSRIs in higher doses can treat depression, but in low doses, it has actually seemed to make a pretty decent difference in IBS patients as well for the prevention of flare-ups. So those are our pharmacological options. So, and then of course we can make it patient based. So whatever the patient preference is, we can base it off of that. Okay, so a summary. So let's just go over everything that we went, that we covered with the IBS. So patho, it is that brain-gut disconnect that is either caused by motility issues, so that's the IBD, IBSD, IBSC, or IBS-M, or it can be that psychosocial aspect. So that's going to be our stress or anxiety, or the post-bacterial infection of the gastroenteritis. And we're going to see this in women under 50 years old. Like I said, if we see that in older than 50, it's probably going to be a different diagnosis. And we're going to see it in people that either have anxiety or stress, or even a food intolerance. So, like sensitivity to the lactose or any of those triggering foods. We're going to see that severe abdominal pain that goes away with defecation. That's our light bulb of IBS when we hear that. And they're probably going to have a lot of bloating, gas, and then, of course, the diarrhea or constipation with it. They're going to meet that Rome 3 criteria. So that's going to be if it's lasted more than 3 days a month for longer than 3 months. And then, of course, the change of the bowel habits with that, or the consistency in the stool. So either harder with the constipation or softer with the diarrhea. Our exam findings are going to be pretty boring just due to the subjective nature of IBS. We may have some abdominal tenderness with palpation or some signs of like dehydration, but it's all going to be secondary symptoms that we see at our physical exam. We went over the Rome criteria, so that's the diagnosis feature. We don't need any imaging or labs. And our plan of care is going to be highly it's going to be highly based on what's causing it. So that's either going to be lifestyle changes, which will most likely make the most difference. So that's going to be our diet changes or exercise. Psychosocial, we're going to want to do like either talk therapy or counseling, teaching them stress reduction therapies, stuff like that. And then our pharmacological is going to be our antidiarrheals or laxatives or stool softeners, antibiotics or probiotics, those medications that will be more of supportive therapy. Again, I have this flow sheet here that I thought was great. I'm a very visual person, so I think that it really breaks down IBS well on how to confirm your diagnosis and what your treatment plan should be. So feel free to take a look at that, and I hope you guys have learned all the stuff about IBS. Have a great night.